Okay, thank you so much for joining the session, guys. Please let me know in the comment section. It is important to participate to attend this class. From which city you are attending the session, please you have to comment on the Zoom chat box to attend this further class actually. So there is a Zoom chat box, guys. Please let me know from which city you are attending the session. That's the only requirement here. All right. Okay, great. So please let me know in the comment section if you can see the screen well. Please let me know in the comment section and we can start. So we had one early class last day that we have been going through this MC part two and a few of the information, some nice things I will also show you today. Great. So our admission, by the way, is on progress. You can join if you want. It's a good course and in reasonable price, definitely. It will be very cost effective if you join. And of course, the content you can see is colorful, notes are fantastic. So you'll definitely gonna enjoy them actually. Right. Now, here we go. Like, last day, what's been done actually. So last day, few things been done. And as I mentioned about few things about the courses already, that course is currently also having 40% of discount, and also very exclusive physical examination is added in this particular course actually. So you can purchase the physical examination separately. You can also purchase the full course separately. Great. So these are some of the points. It's just like um, all right, so this is the update so far with us. It's a good one. And as you all can see, these will be some of the requirement for attending classes. I'm sure you all familiar with Zoom. Few of the things like, some contents will be also given by the Google Drive. Make sure you have some PDF and Word so that you can open some of the files actually. Right. So good like results and the things. We have gone through this on last day. We have also recorded packages. If anyone wants, you can also go and take them. So we'll come back to this particular parts later about the courses. If anyone joining first time, usually our courses is for 4 months, 3.5 months it took. And in future, we are also going to add separately a recall courses like our MC part one. So 1 month or 2 monthly, there will be a special recall course we'll be introducing. Actually, great. Now, these are few of the additional things like, and last day, what we have gone through last day, we have discussed few things, and that is actually about uh, the format of the exam. Now, I'll go little quickly today because this section has been done last day. You can find it out from our MC Clinical Alpha 7 batch. It is already given there. You can go and see that one. All right, so we'll not take much time here because a lot of things we're going to cover. We already talked about how many stations are there last day. And there's another thing because some people are joining for the first time, and we keep getting this question all the time, buzzing, all the time in our messages. Doctor, should I take that MC part two exam face to face, or should I take that one Zoom based, or the MC this is taken like online, like sitting at your home like this, you can actually take this particular exam. So that's like kind of like interesting. Some people couldn't believe that in this way it can be possible even. So it is I want to say like it's very much possible to attend MC clinical exam by online. You just need to make sure you have a good internet connection. So two internet package at your home for that particular month can be a good idea. All right, and some format changes and all this thing we have already talked about that one. The major changes are two. Please remember, we have details discussion has been done. Please check it in our YouTube channel in previous, or check with our Alpha 7 group. It's been posted, or you can check in our Shahriar's Medical Academy page. We will also post that previous video very shortly. We details discussed about the differences between online and the face-to-face exam and that online Zoom-based exam. The percentage of passing is quite similar actually. We encourage or recommend our candidates, probably because they're more familiar with online so far, and you don't have to run too much to go to Australia. You can take it from India, Bangladesh, Pakistan very easily. People are passing consecutively nowadays by sitting at their home, even not by going to Australia. Then they start applying. So you can save a lot of money in that way, actually. And another question is, online course is enough to pass the online exam? Definitely, that's uh, quick question. Is it like this online course is enough to pass that face-to-face exam? So previously, I used to recommend, in spite of attending our courses and the physical examination classes, you still, if it is possible, if you have face-to-face exam, before going for the exam, you probably take a mock test, or also at the same time, I mean, face-to-face mock test and face-to-face physical examination. Now that problem we can solve a lot, because in this new batch, that physical examination there will be over the patient we will show you, so that will be fantastic to cover up a lot of things. But still, if you're going for face to face, please make sure you go with one or two mock, in Australia before the final exam, actually, because you are going for face to face exam. So face to face mock is very important. So since we don't conduct face to face mock, so I would be recommending, if you're going for face to face, at least do one mock or two mock before your exam. So this is one of the things. Now, next point is coming. What are the major two differences? One is the prompt. Previously you just see the question in your screen. Now, nowadays in online based exam, there's a prompt system, and they'll be mentioning that at fourth minute you will get physical examination. I repeat, at fourth minute you will get physical examination finding, because in online you can't do physical examination. Rather, you can explain the physical examination to a med school student. So this is how things are done nowadays. Or you will be directly given the physical examination finding. You don't have to ask about physical examination. So this is some of the updates nowadays for MC part 2 exam. Another, again, I'm telling, is MC part 2 exam, is it possible to do online? It is very much to do online. A lot of people has passed from my academy also by doing that online based, actually. All right, also many by face to face at the same time. Okay, so few changes that has happened. For that one, please check our video by going to Shahriar's Medical Academy page. We'll post the previous class, actually, like 3 4 days back we have taken that class. We'll post that one. You can see more detailing about the difference between that online exam and face-to-face exam. Let's move forward. Let's not take much time, because we'll also do real role play today. Now, those of you who are interested in doing a role play, please drop your messages. If anyone is already our student, like also from previous batch, feel free. You can also drop your message if you want to do a role play later. Okay, so this is the thing. So same thing, face to face or online, we have discussed that part. Stations we have discussed. How many station is required to pass, like at least 10. I'm going a little faster because we have finished these things already. Yes, so please go through these things. Yeah, this is face to face address. You can go easily by going to Australian metro station. You can go there by easily. All right. This is how the original face-to-face looks like. There'll be a monitor, okay, and there'll be bell rang, and you just quickly enter into the room. So 2 minute are inside, 8 minute. I mean 2 minute outside, 8 minute inside. 2 minute to read this question, and then that's 8 minute. Right. So moving forward, if you have any other further question, you can drop us a WhatsApp. Like this is our WhatsApp. Please take note on that one. We'll be just taking few seconds here. You can please save that WhatsApp if anyone is new watching this thing in YouTube or in the page. All right. Now we'll be also adding a lot of physical examination things this time. So I think it will be very useful for many of you. And we also do uh, we'll also give you classes recorded. You can use it also later after the course, actually. So this is some of the few additional good points in this current one. Today we'll do a pediatric uh, role play session, but before going to that one, we'll little cross check with the pediatric history shortly. Now, a few of the things, I mean, very quickly, let's try engaging few things. What are the major points? Before I bring that one, what are some of the major points we see in a history? Anyone, by unmuting and by turning on video, whatever it is comfortable for you, can you mention that, whatever it is, what are the major parts in a pediatric history? Okay, anyone? Yes, Dr. Nandini, I can see you.
Good evening, Doctor. For
Good.
pediatric
Yes.
history, birth history, neonatal history is important. Immunization history.
Okay. If we come back from the beginning, like, let's just start from the introduction, like what points in generally we came across for any history, and then we'll talk about the pediatric history. Now, your question is correct, answer is correct. Let's start from the beginning.
Um, Name of the
Okay.
child, age, from the parents, who's the caregiver, mostly from the mother will be the history from.
Okay.
Um,
It's okay. Go ahead. No problem. Yeah. Hey, this part may help you. Like, when we
yeah,
start, always we look forward to the presenting complaint first.
present,
Actually,
yes.
you always, because presenting complaint, you will get to know from the monitor actually, like whether no matter face to face or online, the chief complaint you will always get to know from the major, because always people need to focus on the chief complaint, because everything, like, is it a child with cough or is it a child with vomiting? So whenever you heard, okay, let's think child with cough. Now, is it a viral cough or is it a GERD cough, or is it a some other sort of cough? We need to figure out that one actually. So whenever we see the chief complaint outside the door, we start processing in our brain. And then comes the chief complaint. These are some of the chief complaint, presenting complaint, like, when does it started? Can you tell me more about this thing? It is recommended not to, buzz the patient too much while he's started presenting actually. So this is one of those points actually. All right. Then more other points like that will come actually, like if it's a pain cases, like, you started with Socrates. If fever cases, you start asking more about fever. If it's a rash case, you do ask about the rash. But a lot of additional things are also included into that one, which also includes like systematic history, past history, family history, allergic history, drug history, social history, and closing a lot of things. Now let's get into exactly what is pediatric history is about. Let's try to guide you in that way. Like whenever this is that original pediatric, how it is looking like. So whenever we enter into a room, say let's focus on the face to face for a second. Whenever we enter into the room, like, you take the the sanitizer as a hand wash, and at the same time, we go and we introduce, hi, I'm Shahriar, one of the GP for you today in this clinic. How may I help you? Okay, so this is a way to start the communication. All right. And if something about examination and the thing, like, you can also tell, uh, at any point, if you feel any uncomfortable, please ask me, I'll stop then. So there's some nice gesture and approach that will be also important to please the patient. And the examiner will also monitor this thing, that how good you are communicating. Are you really giving your best to impress the patient and also bring out the maximum from the patient? So which brings us starting one of those things after this introductory thing with the patient. Say, how may I address it? Say, okay, my name is John, and what's your kid's name? Okay, so and they say, okay, kid's name is Paul. So then you tell the father that, okay, John, do you mind? I mean, I turn to my examiner for a second. So he says, okay. So I'll turn and ask the examiner that, dear examiner, may I know the vital of my patient actually? Okay. If in your exam question, if it is mentioned already the vitals are given sometimes, then later at the exam you ask, dear examiner, when you start physical examination, asking, dear examiner, is the vitals are same as before? Okay, so that can be another thing, that you are really alert about his vitals. Those vital can also deteriorate, right, throughout. So this is another point. So either the most cases, like, you enter and you ask, you introduce, sanitize, whatever these things, and then, you do, you know, uh, turn to the examiner and ask about the vitals actually. So vital you can ask in that way, and they will tell you like, what do you want to know? I want to know about blood pressure, pulse, temperature, respiratory rate, and hydration status. Okay, so in pediatric case, please take note, this is a little extra we ask in the like, as a vital, the hydration status. In some other cases, like, if it is relevant with the diarrhea and the things, then we ask about the hydration status. Otherwise, in the physical examination, eventually we will ask, but it is very important we do ask about the hydration status. All right, now we start the case, like, Examiner will tell you that, okay, his vital blood pressure is 100 by 70, respiratory rate is 18, then temperature is normal, and then they will tell that, yeah. So these particular things, if they tell you, and his hydration is fine, you can continue. Then you turn to the John. John, we can proceed now. John, can you tell a little bit more about, like, how this thing has started? So this is a child with cough case. How this has been started with Paul. It is good. Like, this is the second point. You can take all of your note that, addressing the patient with name carries more mark. So this is a second important secret or point. Like, if you emphasize, like, a mother likes that, you name Paul, with nicely, with some nice word. Yeah. So, sometimes you can also add things like that as a number three, secretive things that, Paul is a really lovely name. So, uh, who, like, did you give the name? I mean, sometimes this is a way of interaction. It might take few seconds, but examiner will give you full mark for that. So you have to invent something, which we also use for day-to-day communication. If the examiner see you that you're really in a hurry and you are not really trying to communicate here, okay, so this might be cutting off your mark. So please remember that approach has a lot of mark. So initial, all these things which I'm just now talking are all related to a bulk of mark actually in the initial approach, whatever we are just talking. Also, another thing, when I enter, a lot of people make a common mistake. Hi, I'm Dr. Shahriar, one of the junior doctor in this hospital. Now see, two times telling junior doctor is a wrong thing. Hi, I'm Shahriar. You can call me Sherry. Sometimes it's like that. I'm a junior doctor in this hospital. I'm here to help you today. So this is nice actually. So be confident when you enter into the name. So mention that, one time as a doctor, that, like, I'm Shahriar, I'm the junior doctor in this hospital. Now, this brings to another point. Some people do not check the question properly. Always you will be given a question in your monitor. Um, some people ask us this thing, doctor, when I enter into the room, will I get that question in face to face? Yes, you'll get that question. Okay, so you'll have the paper or you'll get that monitor even inside the room. That's how it will be actually. So the paper and the things are given actually. This is another thing. So keep that one in mind. You'll get that support of the paper and all these things. So do not worry about that one if you forget something, but try remember the most of the points. So one important thing, many of the doctor, they don't give emphasize what is your position, because you are all the time practicer. Hey, I'm Sharir, one of the junior doctor in this hospital. Out of you know practice, it came up sometime. But you need to see, is it a GP setting or is it a junior medical officer, is a senior medical officer, and all these things. Usually your position is never almost mentioned as a consultant, but if someday it is mentioned that, as a consultant you also have to mention. So clarify your position, very very important. These all the parts are related to your initial approach, and this carries more marks. At the time of the day, we know we'll proceed with more systems. Different system may take a little different approach. Actually, we will talk about that one. But this particular introduction, hemodynamic instability asking, is also important. Now, this is the one way that examiner will tell this, and you find it normal. You can proceed now. Thank you so much, examiner. John, can you tell me, proceed now, or can you resume now? Like, can you tell me again what brings you today in this clinic? That's how we started. Now, the second scenario, examiner will tell his vital is 80 by 60, pulse is 120, respiratory rate 35, and temperature is actually cold clammy skin, or they said like 95 Fahrenheit. Now, this is a sign probably the patient is in bit shockable state. Now, how to this, let me see if anyone from our academic doctors, they know how to present this part. That these are the some of the vitals. Like temperature is 95, respiratory rate is like different, like 35. Then pulse is high, and also that blood pressure is you know kind of like a 80 by uh, you know 40 or something like that. So a bit unstable. So what we tell the examiner in that case? Any guesses? Anyone wants to add something, or otherwise I will tell. Don't worry, I'll help here. Come on, guys. Anyone? Let's take a little. Okay, Dr. Tasnuba, can I know? Dr. Tasnuba, can you give a little hand if it's okay?
I think you
How?
just have to ask the doctor about would the patient needs to be transferred into the resuscitation room, and we have
Yeah.
to we have to give IV fluid and to stabilize the patients. And also
Excellent.
because the patient temperature is very low, did you say 95 like Fahrenheit? It's a bit hypothermic, so we might need to also give warm blankets to make the patient much more warm to avoid hypothermia.
All good. That's like, so this is one of the thing that emergency cubicle. This is a part, something to mention actually. Emergency cubicle, like you are transferring the patient. Now because it's a main exam going on, you also need to ask the examiner that is my patient is stable now to continue. So examiner say yes. So then you continue in that case. So this is a two phase. One, they will tell most cases that patients vitals are fine. Some rare cases they will tell the vitals are not okay. All right. So in that case, you have to take the patient to the emergency cubicle and then ask the examiner is doing well. Third scenario, let me tell you here, with sometimes with pain it came up actually. The patient is on pain. You see in the screen that patient is on lot of pain. If your patient is on lot of pain, you quickly in the beginning, hi, my name is Shahriar, one of the GP in this clinic today. I can see from the notes. Now, please take notes how to address things like that. Sometimes people didn't get words actually. I can see from the notes. Notes means that what is mentioned outside the door. So I can see from the notes that Paul is on lot of pain actually, or maybe because you already get to know, like from her that name is Paul, or you have to ask otherwise, your name and your kid's name, and I can see from the notes that Paul is in a lot of pain. And so, like, did you give anything yet, or do you want me to give some painkiller to Paul? It can be pediatric cases, it can be in some general cases. General case, you can directly ask. So in that case, you can turn to examiner, and you can also rate the scale in pain, if the patient himself is affected. But if it's kid's case, you can't really ask in that way. But do you think it's a very severe pain? And yeah, he's been crying a lot, like crazy since. So you turn to examiner and tell the examiner that you want to give painkiller, even though you have to ask, like the John, that you want to give Paul the painkiller. At the same time, very important at this point, many people make a mistake here. Does Paul is having any kind of allergic to any kind of drugs? Okay, so this is very important because we are going to give drug. Is Paul is allergic to any type of drug, or is Paul is taking any type of drug? So this thing asking, then go to examiner. I mean, turn to examiner, and to give Paul a painkiller. I mean, you can name anyone. Then examiner will tell, okay, pain subsided, you can proceed now. They're very smart, so don't worry. Actually, you don't have to ask them everything every time. Actually, they're smart. Actually, you just need to mention, and they will give you the instruction what to do. Okay, this is how done. Then you start asking the history and all this thing. Now, anything that like say pain cases or anything, how did it start? Like how long it's been, severity, scale in a pain thing scale. If you see uh, how it is affecting, is there anything living in? Did you give anything for the pain? Is it continuous pain, or is just going and coming back? Can you explain the pain a little bit more? Is there anything relieving? So these are some additional things you need to ask. You do also need to ask about anything associated. Is this pain is associated with any injury or anything else we need to know? Is it associated with any other uh, symptoms, like example fever, any shakiness? No, like some. Now here is a tip to save some time in the history. Some people ask, is there any association with fever? No. And is there any associated shakiness? You don't have to ask every line every time. uh, John, I'm going to ask you a few quick questions. Any association with fever? No. Any shakiness? No. Any rash? No. Okay, anything with the anti problem, like discharge? No. Like, see, the words you can play, it can save your time. Okay, so this is how you can become smart. Actually, few more tips I will tell, like how we can do a lot of compilation of lot of these sentences. Will show you in coming days as well. It's also very important. All right, now next thing is like pediatric history taking. Actually, now in pediatric history taking, we're talking about when we enter, like in generally a lot of things, like say if you see this one, like already we saw something with the pain. Now cough also has certain way of asking cough, like when this started, can you tell me this, that? But there's some more things. It is productive, is it noisy, anything associated with shortness, any runny nose, You can just ask this thing very quickly. Is it sudden or gradual, or is it only in the daytime or wake him up at night? So you can ask this type of things. Or is it getting better or worse? What do you think in last week? So in this way, you can ask the question, has it been associated with vomiting? Now, a quick question, let me see your ideas. If cough, which is followed by vomiting, and this cough has a history of 2 weeks, what do you suspect in that case? What do you suspect in that case? A cough followed by vomiting, and this cough has been persisting for 2 weeks. So
What
this
do you
cough, what do you think it can be? Yes, please.
what do you say, sir?
Pertussis, yes, well done. It can be a case of pertussis. Pertussis has a keyword. We'll see that one very shortly. Like the cough followed by the vomiting thing. So this type of key liner thing are also important. You can also ask these things very specifically in the exam to be sure about your diagnosis. Same goes with the things, quite of similar with the coughing cases and with the vomiting. So how often, amount, content, food, stool consistency, and blah blah this thing. So these are in general because it's a history taking format. So that's how it is given. So if the child is well or not, feeding well or not, hydration well or not, weight is all or not. So this particular thing additionally comes in the pediatrics actually. All right. Last there is a line. Sorry, before moving from this slide. Anyone sick at home? Any recent travel? These are some interesting question. Anything with daycare? Anything with school? Anything similar issues, or similar diseases with someone. So this is very common in kids cases. Often kids goes to the daycare center, right? So you need to find a proper history to rule it out. Actually, any recent travel history, is any other family members affected, is there everything good at home? Sometimes we ask this tricky thing. This is somewhere indicating why the child is behaving like that. Maybe something is wrong going with the child. We don't know, maybe an abuse or sexual abuse or anything. Is everything in the okay with the child at home? Who's taking care of the child? Okay, so this kind of question will increase your mark. But you need to understand, case wise your question pattern can be changed. Actually, some question you can give more emphasis, some question you can give less emphasis, depends on the what case you are getting. So pediatric history taking, at the end there's two things that come up, that is like topes and the binds. What is topes and binds means, there's a little bit things are told like birth history, someone mentioned in the Dr. Nandini. So birth history is a specific here, immunization, nutrition, development, social, and blah blah this thing. This is another way, which is this upper section has been taken from the handbook, and this section has been added this to particular section. You can also ask in that way. So TOPS and the binds, two things is very easy to remember. TOPS is a travel, occupation, pets, exposure, and smoking. You need to ask these things actually separately. Have you been travel before? What's your occupation? Can you give time to Paul? Any pet at home? No. Any exposure? Any allergic history or exposed to any allergy in your known case? No. Anyone in the family is a smoker? No. Then comes the binds few points actually, because it's very important to the biology. Is Paul is having a, like say, is Paul is having, is your child, this is the one way, is Paul is having a like normal delivery or any history with in ICU admission, something like that. You can ask it one, is Paul is having a normal birth history, or so basically we'll enter into the asking about the birth of the kid, like what was the weight, any resuscitation required, was the kid was taken to in ICU or not, has Paul been duly immunized, yes or no, then nutrition, then development. You can also ask for the growth chart to the examiner. The examiner is there any supplied growth chart, so you can see the development in that case. And lastly, social actually. Is there any support at home? Who is supporting Paul actually? Why is behaving like that, do you think? Okay, so this kind of thing can be additional binds at the tops. These are the some additional things. So pediatrics history, as you all can see, past medical history includes any surgeries or anything has been prescribed, any similar condition for the family members. You can also ask that one. Now, next comes to the physical examination. Last year we are talking about the same thing. Previously, we all learned the physical examination is of two types, general examination and systematic examination. For the exam, it's better you remember as a three-pointer, like a general examination, systematic examination, local examination. Three things will be better because often it is related to child with rash or child with a very specific finding, which is separately you need to ask history. So it is better to remember general, systematic, and local. Some cases local may not be required actually. Okay, so child with rash cases, you need local examination like that, or one to other cases you need to do local examination like a lymph node cases. Okay, so that's the part of the local. Now here you can see, when you come to physical examination, but talking about the face to face, in the uh, online exam, this whole screen will come in front of you as a prompt. Actually, it will come in front of you actually at fourth minute. Most cases it will be mentioned in the question that at fourth minute you will get the prompt actually. So this is how in online based the physical examination is done. You will be given the findings and the physical examination. In that case, you can't ask anything to examiner in online based exam. Actually, it is developed in that way that you only talk to the role player, not the examiner. But in face-to-face exam, like we went, that it's all related to the patient, the role player, and also the examiner. So physical examination, often we used to ask physical examination finding directly asking the examiner, and some of the cases directly physical examination. Okay, coming to this part, general examination, these are the things to ask. We don't ask the all 24 points, we ask specific points actually. So you see pallor, icterus, clubbing, cyanosis, lymphadenopathy, then the rash. Describe the rash. What sort of rash actually? From where it started? Is it started from the head or from the center, or so distribution of the rash. Then is it like a type of rash, characteristics of the rash? This particular thing you need to ask is there any squamation, desquamation in the rash? If it's desquamation, yes, this can be Kawasaki. I'm just giving example. In the child with rash cases, we'll see more details actually. That will be our one of the next class, so don't worry. Sign of dehydration, vital growth chart, systematic, focused examination. It is very important, like a specific, say if it is a case related to GIT, you highlight more about the GIT in that case. Last but not the least, don't forget to ask about is the hernial orifice and these things are intact. Do ask about that one. And we do ask about the office test to the examiner in face-to-face. In clinical exam, I mean online based exam, it is being given if there is any significant finding. Okay, so these are the some of the office tests like sugar, that this like ECG, spirometry, and all this thing, yeah, can be included. So past history, after past history, then this physical examination, particularly office tests, ask the examiner. Very important. No tests is available. These are the office tests you should ask. Okay. Now the history format is gone. Now come the popular clusters. Now I would like to take some questions from the dear doctors. Would you like to ask few things here, like from the history part? Actually, guys, feel free to ask if anything you want to ask about the history part, or do you want me to continue? Please comment in the comment section. So far, you guys are okay, understandable, guys? Okay. Please comment me in the comment section. Please do let me know if things are going on in your way. Please do let us know. Okay. Coming back to this part, which we called the cluster. So these are the in generally. So if you are a beginner, trust me one thing, that quickly, if you try to um, literally want to do so many things, it will be very difficult. Unless you got exam date in suddenly in 1.5 months, then it's a different. But the ideal, it's fun to study if you start reading as a cluster. Now you should think as a what are the child with cough cases. If you remember, those are our students in part one. There's a some boxes we used to left, and I used to tell them, these are for your MC part one someday, part two someday, right? Like there's a bunch of questions and some list of causes or the differentials. In the beginning of most of the chapter, imagine the headache chapter. In the headache chapter, in the beginning, there's a big list of causes of headaches are given, and there's some questions are also there. This is a part of the MC2 actually. Now you have to remember most of the things actually, that part. Okay, so that's few of the things, but you need to also figure out which cases comes more. This is also important. But if you prepare in generally like as a cluster, if you prepare like most cases will come nearby to this. Most cases will come very nearby to this. All right. Now, somebody to ask me, I'm not sure if anyone is a candidate for NZRX here, actually for New Zealand-based exam. So in New Zealand-based exam, the difference is not so much. Mostly, there's like two suggestions for them. You have to follow the MC clinical syllabuses, most cases. Even if you call the New Zealand exam authority, they also ask to follow the Australian guidelines actually. So this is one of the thing. And how similar is that one? 80% would be similar. The 10% or 20% different would be, you can see the NZRX recalls actually. All right, so this is a suggestion actually. All right. Okay, so this is some of the part of the things I just wanted to highlight. Last day we discussed that there's a book named John Murtak, Patient Education, some of the follow-up and some counseling thing you can also check from the John Murtak Patient Education. Few things are nicely written. If you're using our notes, it will be already mentioned, but if you can also separately open it. Now, whenever you study, example, say you joined us, then mostly how you will prepare. That of course you come to the class done, next day how to prepare. Next day you open the laptop, you open the note. If you want, you can play the video again. Your self preparation you can do if you want. When you are done with that one, you ask for your study partner, okay, let's come and start doing the role play. In the same cases, you start doing the role play, you see the notes. This is how it's given in the notes section, so you keep it in that way. Now, one to extra book you can also open near to you. That is like you can open a handbook near to you. Say one of them can be a handbook. Next, another thing, it can be John Murtak patient education. You can also keep near to you. So these are the particular additional things you can keep nearby. Another thing, there can be a Marwan. You can also open the PDF of Marwan actually. And another key thing, there's a search option in Word file. Like you can put Control and F, and it will quickly take you to the search option of any file in a Word file like Marwan, and you can type that disease name, say into susception. You type into susception by putting Control and F, in the laptop, and then type into susception and then enter. All the into susception cases will come in front of you. Okay, so this is a magic trick. Some of you maybe already know, but otherwise it's very useful actually. So this is a way to find out the things. Same thing in our drive. If you're trying to find anything, there's a search option. You can also search it actually by name, like pediatrics cough. The note will come in front of you very quickly. All right. So this is few of the things, and yes. So this is a small tip how to initiate preparation. Follow the classes. After class finish, the next day play that video again. Finish that one. Call your friend, start doing the role play, and keep a John Murtag patient education. Then you can also bring the main John Murtag because you have studied it so many times for part one. Recent graduate, definitely you can keep that one. Then the handbook in the other side, maybe Marwan. If you have a hard copy, that's okay. If you don't have, and if you're comfortable with the soft copy, it is even more better to see the Marwan in the Karen. Nowadays has become old. Even Marwan is becoming old actually, but it's okay to have a second resource nearby. Okay, clear everyone? Some instructions are clear, guys. So I'm just trying to give you some instruction how to start preparing actually, how to start. Attend a live class. Next day you see the recording of that one. It will be there in your drive. And call your study partner and start doing the role play straight away. Is it clear, guys? Please comment in the comment section, or you can tell please continue, either of the thing. All right. Okay, moving forward. What to study for pediatrics? Okay, already been mentioned. There's a lot of things related to cluster. So new cases, old cases, since we mix up cases. So these few things can be new cases. We'll also see again, while attending the courses, if there's any other new thing came up, we'll be also definitely adding that one in that case. We'll also give you the guideline in the handbook cases, like these are some of the handbook cases. While you prepare the pediatrics, you need to also finish these handbook cases. So previously, there was a technique people used to follow that, okay, I'll finish the handbook, then I will start some course. Actually, we're still in the blind actually. Even if you're finishing handbook, that is not how we actually tell in the main exam. We can get the essence from handbook because they're so long. In main exam we cut short lot of thing actually. So in handbook the cases are given really really long. That's how we don't talk in the main exam actually. But the cases are useful. Some very important valid points are there actually. Okay, so especially sometimes some critical error are being mentioned in the handbook. Like if you don't mention this one, like example, a pediatric case, you don't ask about the hydration, you are failed. In that case, failed to make a proper diagnosis, failed to make a proper diagnosis. Again, you are failed. So you also need to know what are the critical error for a case. It's a peripheral vascular disease case. You forgot to ask about pulse. How come you passed the exam? Okay, so these particular things are useful in the handbook, right? So it's huge, but when you start preparing, now better you attend our you know classes and cases. As long as it goes on, you follow that one, things would be more easy for you. Now you try to find out if any cases are related to child with cough here. Okay, so usually we go in that way, that if anything related to child with cough or pediatric cases, these all are somewhere are your pediatric cases actually. Okay, so you can follow in that way. If any case relevant of any of the lecture day, okay, you can follow that one. You can see pyloric stenosis. Our another class or second class is the pyloric stenosis. So this pyloric stenosis is there. After you attend our classes, then if you see that pyloric stenosis, things will be is very easy for you. You already know what to tell. Then you see if there is any extra topic to take from the handbook actually. Otherwise, you read handbook, then again you come to our classes, then then what's the point actually, right? We're already giving you the key points actually in the notes. So it will save your time. You just check the handbook as a resource, definitely, that you are not missing anything important. This is how, if you proceed, you can quickly finish the syllabus. Best way to finish the syllabus. Now I'm telling you, follow our notes, follow our lectures, then open up the handbook, open the Mar1 and additional thing, John Muttak patient education, and combinedly keep studying actually. Keep your eyes on, like in groups like MC Clinical Exclusive. Any new case come up with pediatrics, you check that one quickly. This is how to proceed. All right. Sequences to follow. What do you mean by that? Last we talk about that one: approach, history, PEFE, investigation, DT, management. So this is the sequence to follow, but not all points are given together. But approach is included in every cases. With the time progresses, different system will talk about different approaches. To be honest, even if you go to psychiatry, your approach is even more different, what I just told in that class actually. So Henny will come for that psychiatry. She does good role playing actually, during like the psychiatric session actually. She can act very well, by the way. So that will be good actually, to do some of the role play with her with psychiatric cases. This is how the case is given, it will be displayed. This is the case given. This is for a mother and all these things, task, and these will be the things given. So you'll be given 3 or 4 STEM and you have to perform that one. So please always check, for God's sake, what they're asking. Are they really asking history? Some people, history is not asked actually to take, or history taking was not included. Okay, so they start asking history. And many times it happened with our classes as well. You'll get to see that, oh, sorry, doctor, I didn't see. So main exam, there is no option for sorry. So please be careful on that one, that it history is required or not required actually, because all segments are not given in the main exam. Very, very important point, this one, please to be noted. Okay. Some rash cases, we'll see that one. No worries in coming days. These are the cases, we will cover actually, so in rash cases, but we'll again cross check if anything new came up. Definitely, we'll definitely also talk about that one. So these are some of the very classic for last 2, 3 years, 4 years. These cases are coming so often. So first, please understand one thing. You don't know much things about MC2 if you are new. So first secure that one. You like, some people think, oh, okay, which way start, which academy to start, this that, for God's sake, you start preparing first actually quickly. And everyone is quite good in like in MC part 2, to be honest actually. So it's fine actually, any one you take, but you start early. That's most important. MC1, we have significant difference between any other academy in terms of resources. Other thing, MC2, I would say, all are good actually, and as long as, because it is related to role play, so as long as that one is, all are good actually. Probably our note section is a bit more advanced than any other actually in MC2, that I would say actually. Otherwise the role playing is thing, I think anyone can do. Every tutor is good in terms of the role play. All right. I try to do one thing. I try to involve one of the role player who is OZ. I mean, by born. So his accents can be different. So some of you will enjoy that one. Not about enjoy, you need to understand his accents. So this is one important thing, because a lot of people practice with their friend. Sometimes also while going to the mock, they practice with also the candidates who just passed. So there's a biasness, because in original exam, it is something happened that the role player are OZ. All right, 90% role players will be OZ, not a like exam candidate sitting that, and their accents would be very different. So so my accents is understandable. I'm Asian person. Most of you are relevant to Asian, so I'm understandable. Not that typical Aussie accents, but we'll show you how it's that actually. So other than me, Intessar will there be there. Henny will take some classes, and most of all our doctors are already working in Australia, so that you get that experience. And important point, what to tell actually, especially a lot of legal things out there actually. All right, so this is one of the thing. Any important mistake, remember, will make you fail in that main exam. So it is very important. We teachers also sometimes discuss what to tell, what not to tell. For some cases, this is a matter to discuss in MC2, because what you are telling, please be careful on that one actually. If you're telling unnecessary things, they will mark that one. And if it's a wrong statement, especially child cases and ethical cases, if something wrong you tell actually, maybe you find somewhere someone's feedback, you don't know that person passed or not, or is that statement is correct or not. So you might fail in that one. Okay, so this is very, very important. You clarify this thing. There'll be allergic cases. These will be some of the allergic cases we'll discuss in coming days. This will be the cough cases, which we will discuss today, that bronchiolitis, asthma, post-viral, and some pertussis, and child with vomiting cases, ERD and PS. And also there'll be fuzz eater, innocent murmur. There was a case, otitis media, and one, two, there'll be miscellaneous. That is how the things are. About physical examination, there is no real patient in the main exam. If online based, you forget about anything, you don't really have physical examination, except physical examination finding you need to remember to explain to a medical students. Cases are like that online actually. So physical examination things are much easy in online exam, but you have to be a good speaker actually. Like example, if you ask me, doctor, if you appear now again, like to one of the which exam you want to appear, and I would say online, because I've been teaching, I can express well, actually easily. I can remember a lot of things. So for me, it's more easy because I'm good with the vocal actually. So it's about yourself, that if you are good in talking, if you are, um, so maybe that's okay. But those of you who are living in Australia, maybe you can take that exam face to face. It's a kind of experience you will never forget by going to the Melbourne, that MC exam center, 300 lat drops. You go to that I think 13th or 14th floor, in the lift. You go there, then the security check, then enter in this. This is some experience of your lifetime. You'll not forget. I have a video on my YouTube channel. Just shooting, near to the MC2 center. Actually, it's very difficult to find out, guys. So do not try that. You don't know the place and you're trying to go for the first time, you will be in difficult situation finding that one. Even Google will not help, because it's a very tall building, and it is usually in our country things are not mentioned. AMC Clinical Exam Center, you will not find anything like that. Suddenly you enter into building, going exactly to that particular room, then only you will see, okay, MC Clinical Exam or MC exam or MC council, that is written actually. Now, only one thing, that neonatal examination, head to toe, some cases they ask actually, okay, for neonatal, but that is no real patient is given. All right. So we have a physical examination, 6 to 7 sessions. It's there, we'll also give you that one. So do not worry. So we have both now actually online, and also that face to face. Face to face, a new one. I think I show a little promo last time. Maybe you have seen that one, that little promo in our group. So maybe it can be very, very useful for all of you. We'll start the session now. Actually, so great. Right. Okay. This is the few things we're getting for our session for the role play now. Now, those of you who are interested, please let me know in the comment section if you want to do a role play. We'll go for some child with cough role play. cases. Anyone please step in, feel free. I'll try to explain the cases and then I'll do role play because it's easy. Even new doctors can also attempt. So no, I don't mind on that one. Because the very first thing is sometimes difficult. So once you overcome that fear, you see, you don't hesitate ever doing a role play. So this is the very first one to role play. People get really scared actually. So I'll be happy to help. I'll not criticize anyone if someone tries a role play today actually for the first time. Anyone here? Feel free, guys. All right, just a second. Let me bring that slide. Oh, okay. Okay, let's get going. Let's get started. How it goes. Let me see actually. So last some 1 2 people to come up there if that's okay actually. Okay, so let's start in a minute, guys. Let's take a 1 or 2 minute break before we start that one. And mostly cases are not so difficult. Like these, some resources and the things. These are the clusters. We'll go for that. The child with cough. This we are here. Okay, so yes. Now I'll give you 2 minutes, guys. Please focus on that one. I'll give you 2 minutes here actually as a break, maybe, or 2 3 minutes. You try to memorize this thing because most of the things, this is like that pearl actually. This is the nutshell. If you understand this one, you will be able to crack any cases. Understand the format, then put everything in the format. Will be fine. Okay, Dr. Tasno expresses to come. Okay, so granted, you can do the first one. After 2 3 minutes, maybe we can start actually. Thank you so much, everyone. So after 2 3 minutes, we'll start. If any other interested after seeing Dr. Tasnova get inspired, then you can also start, right? Okay. So in next 2 3 minutes, don't go away. Please keep reading this slide for 2 minutes because what is negative history, I will also talk about that one very soon after the feedback session. Okay, everyone. So let's get started. So this is a I would say very interesting slide coming up. We'll start the role play shortly. Dr. Tasnava will do that. We'll invite her shortly. Let's bring out. We just get to learn about the history taking. So in a history taking, normally, presenting complaint, then there would be anything with cough. We ask a lot of things. Then the past history, family history, then social history, then certain things come up, especially binds and the tops for the pediatrics. Just while ago, we mentioned what is binds and the tops. It's the mnemonic. We'll also get to see that. And then, after doing that, we go for physical examinations. Sometimes in online exam, it is given already physical examination. Otherwise, we have to ask the examiner. There is no real baby to perform physical examination. And after that, there will be some cases investigation, diagnosis, and DD. Okay, not everything is given in one particular case, or otherwise they will give you a scenario. Scenario is big. Scenario is big means you probably don't have to take the history. Please take note. This is another important secret thing, that if the scenario is big, it means this case may not require any history. Then just to confirm, check what are the tasks are given. So you'll see that asking, give the differential and diagnosis, and talk about the management and follow up. That is how it will be given actually. And the scenario would be longer, means the history, a lot of part will be given in the question. Okay, so please understand this important tips and tricks. Now, among the all these things, we all must be knowing that most common would be the type of cough is a post-viral cough. So this is another case that comes in the exam. If it is a repeated respiratory tract infection, this is some of your part one knowledge is helping here. Repeated respiratory tract infection is a cystic fibrosis. Guys, what we can do, you guys can unmute and also can answer these of the particular things. Okay, I don't mind on that one. All right. Next is a child with abnormal sound. You can see what it can be. What do you think? Abnormal sound, wheeze or stridor. So this particular thing can be croup. Croup is a popular case in MC Part 2 exam. But here, important thing, cough with stridor. So normally we ask, is there any abnormal sound you heard? So this is another thing, or any sort of barking cough. So this is going with the croup. Next coming, let's see more critical cases with a cough with the abnormal sound. Cough with abnormal sound. Cough with abnormal sound or cough with wheeze. Actually, this is separately we asked actually often. So with the stridor, inspiratory, expiratory, that only examiner can confirm you. Of course, the patient cannot confirm you. Like critical and this drooling, this can be epiglottitis. These additional things you can definitely can confirm from the examiner. Bronchiolitis, we all know it's less than 1 year and respiratory infection, often respiratory syncytial virus, and there is a musical sound. Use layman's term. This is another tips and secret you must be all knowing. You can't really always use the medical term. Is there any wheeze? No, you talk about, is there any musical sound, or flute like sound, and it's tracheitis. Like this goes with the bronchiolitis. Next coming is a child with a 1 year of age and cough for like 21 days and cough followed by vomiting. This is a key word. Whenever you ask this one in the presenting complaint as an associated feature, like is there any vomiting followed by the cough? And I say yes, so in that case, that will be pertussis. And of course, the long history of cough is also evident. The same long history of cough can be also tuberculosis. But in that one, you are expecting hemoptysis or low-grade fever and some other TB features. Now, out of all of them, the child can fake or parent can fake whatever it is. Most cases, of course, it is the child actually, especially it has to be a little bigger child, not like a small kid. So school going kid, kind of like school phobia, unattended other time. So it can be a psychogenic cough. Like example, they will be telling, oh, mommy, I'm sick today and this, that, he does not like to go to school actually. Now, you sometimes have to also find out the behind the scene why he's doing that, why he does not want to go. Is it like he don't like to study, or is something wrong is going on with him, with his school? Like there's two three things in his school. Example, teachers are very strict, then the bullying thing in his school, or any physical abuse is going on. The physical abuse can be some of the classmates, they're beating him, or any sexual thing by from the some senior person is trying to do. So this additional thing also you need to exclude actually in this type of cases. All right, everyone understood this particular points? I hope that is a yes. Actually, please comment in the comment section if things are understandable. All right. Now, cough standard history taking. Like whenever cough case in front of you, this is like the presenting complaints. Do you have a cough? Okay. If it's a pediatric case, let's say, okay, you said Paul is having cough. How long is having this cough? When did it start? How often is having it? And at what time of the day? Can you tell more about that one? Or initially, like there's another tip. So when you ask him that open-ended question, they will be telling, they're instructed to tell, oh, like, doctor, don't say Paul is having cough for last, 5 days. He has a sore throat now, he's not feeling well. It is just getting worse actually with the time. I thought, I give some, some Panadol and the things that it is not helping anything. You see, 3 or 4 points in the presenting complaints patient himself or herself told. So in that case, you don't have to ask them separately. So in that case, you straight away ask what is extra you don't know actually. Have you seen anything unusual with the cough, like a blood or has the clause been followed by vomiting? Now, these are the past are the part are related to negative history. The more negative history you can add by asking, is this cough is associated with vomiting? No, pertussis is out. Examiner will also give you tick for that extra mark. It is kind of like that. So this extra marking thing are very important for the exam to remember actually. Okay, so this thing cough with cough, it's the color, blood in it. All right, so you see the patient will also tell you, is there anything that makes it better or worse? Makes it better. So you don't ask things separately. Try compile so that it saves the time actually. Is there anything it makes it better or worse? Okay, so try understand how to compile. More you will see our role play and the things, you will get to know. You'll also learn from a lot of the other candidates. Some of them do really good role play. Okay. These are the cases, already we just saw just a while ago. This can be some of the things. All right. So just learned about the presenting complaint. These are in generally to ask, but a lot of negative history which is not mentioned here, you ask separately, like is the cough is followed by the vomiting. So for that one, the negative history it's given here. Or any hemoptysis excluding the TB, or any abnormal sound or stridor or anything like musical sound or wheeze. No, it means not, it's not bronchiolitis. So when you do that, you get full mark for that. So for initially the approach, which I told you in that way, if you follow, you should find your own way. It's also very important. You should find your own way that of telling that one. It should not be looking like a copy. All right. So if you do that, find your own, technique. So in that way, the examiner will definitely give you full mark for the initial approach. Then that the history taking part, you start with the presenting complaint and you ask one to nice negative history. I can guarantee you get full mark in the history. All right. A few things about cough is given. We know what this cough is about. References to read about cough. Now, RSAGE guideline, I'm sure most of you know. We often check the guidelines in the RSAGE guideline for the pediatrics. Yes, please keep that one in mind. All right, this thing will already been given, that handbook cases and things. Most common causes that is included in cough. Is also this type of slide. If you remember in handbook, we used to see what are the causes of cough. This is in general, it's been discussed actually. Okay, so causes of cough, like then presenting complaint, negative history, try to exclude, try to settle your diagnosis. Okay, try settle your diagnosis first probably. Then you think about physical examination, this, that, so settle your case first, establish then your case actually by physical examination, investigation, and a lot of those things actually will help you on that process. All right. So already been few things been discussed, but more other things it can be, as you can see. Those are those very common one we used in the negative history, but this is in general even more. Like, same things are also given here, like, ZERD after feeding, or if there is night syndrome or bloating, you can also add that one. Pertussis we just discussed. Post-viral cough, like, prolonged dry cough after viral respiratory tract infection. Congenital heart disease can be associated with cough some cases, but there will be failure to that, psychogenic cough otherwise. The same thing in just a little different way. Red flag pointers for the cough. Now, if you remember, a lot red flag pointers was not necessary in PMC part 1. Now it is necessary actually, like, over 50 smoking, blah blah, this thing. This is how it is necessary in part 2 exam. It is necessary actually for uh, at the end, actually at the end, last, if you remember, we talked about the 4R. Now I would like to ask their doctors, who can tell me what do we mean by 4R? 4R, after telling the management, we use the word 4R. What does it mean? Anyone just unmute and tell, would be really nice. Anyone? What do you mean by 4R? It will be quick if anyone mention it, or you can type it, whatever it is, that's all good. No one? No one is sure about that 4R? Come on, guys, it's important. Okay, thank you so much, doctor. So refer, definitely, refer is one of the very important, very impressive. So refer, review, then here is some reading materials, like example about the disease cystic fibrosis, some reading materials. It will give you more idea about your disease condition or Paul's disease condition, and the red flags. Lastly, you can say. So all these things, are somewhat important actually. So review, refer, red flags, and all these things. So you can, and please come back. Please come back if you see any hemoptysis, any unexplained or weight loss, any fever, along with the cough. So if you tell 3, 4 very important one, now your red flags are covered. Is it clear, everyone? Please comment in the comment section. After telling the management, if you technically involve the 4R, again, you are properly finishing your case. Okay, like now you thank properly and go out, that's a different thing. But when you tell the 4R properly, your means you're properly closing your case. Some people just tell the management, the bell rang, they go out, means you didn't close your case. Okay, remember that you lose your valuable marks if you don't use 4R. Then it is. Now here is a technical point. Is every time 4R is required? Now I'm going to a technical question now. Is every time 4R is required? What is in your experience then? Sometimes we also don't need to mention this 4R. In which cases? In the cases where hospital admission is required. Say example, a pyloric stenosis case, will you refer this patient? I mean, go home, get treated, we'll give you treatment. Or pyloric stenosis case, you admit now. We are admitting you, and we'll resuscitate. So we'll admit you and resuscitate. So in this type of pyloric stenosis cases, probably the 4R is not much significant to involve. Is it clear, everyone? So if it is emergency hospitalized case, your main concern, this is another tip, guys. Many of you did not mention about the hospitalization word, actually, where it is necessary. So fail to realize the severity, you fail in that case. Okay, many people think, oh, I'm knowledgeable, I know about pertussis, well, I know about no, it is not about always just knowledge. Actually, here is the technical point. You fail to realize that this is required hospital admission. You fail the case. Okay, so this is important. So please take note, understand the severity of the patient, realize the importance of hospital admission if it is required according to mild, moderate, severe case. Mild case, of croup, you are not going to admit to the hospital, but definitely a moderate or severe case of croup, you're definitely going to admit to the hospital. So these are some of the very, very important point. Keep it in mind. All right. So a few of the things, like how, let's get into the role play quickly. 2 minutes outside, read the case, bell rang, and then they'll be entering the room, special sound, enter, ID verification, then in examination, all good, you may proceed, hand wash, start the case. Everyone clear? Please, you guys are not cooperating. Some of you, I may leave soon if you don't cooperate, guys. Is it looking well? All right, at least you need to response. All good, guys. All right. Yeah, you need to encourage the more, speaker as well. Otherwise, in a quiet room, I feel like, I'm just acting, so that's all of the thing. So just try a little bit, motivate the, mentors as well. I mean, good, bad, whatever, just try. Now we'll be coming up next one. I think Dr. Tasnova, if you can come to role play for this one, would be good. All right.
Yes. I will be doing online exam. So
Online you're going to.
yeah, because I have work, so I can't travel.
Oh, okay. Mm.
Like, is it still okay? Or
All
you?
right, you can. But this one, I mean, it's okay. You can proceed how you'd like. No problem on that one. You have a 2 minute. All right,
Yeah.
so that's okay. Thank you so much.
Mm.
All right, before you start, I'll just take 15 seconds. Just give me 15 seconds, please. Yeah. All right, so we can proceed now.
Okay. So examiner, this is my ID.
Okay, looks good actually.
Yeah.
You can proceed. Thank you.
Okay. Hello, Margaret. I'm Tasnuva. I am the junior doctor here who's going to help you today. I have read Sarah's note, but before we can proceed any further, I would like to talk to my examiner regarding your daughter's condition. Is that okay?
Yeah, that's okay. Thank you so much.
Examiner, I would like to do further examination of Sarah. Can you first tell me the vitals of the baby?
All right, so the vitals are currently blood pressure is 100/60, pulse is 90, and at the same time temperature is normal, and respiratory rate is currently 25 actually. Is there any other thing you want to know?
Yes, I would like to know the oxygen saturation if the baby is cyanosed, and I would like to know the hydration status as well.
All right, the baby is currently, the saturation is 95, and the baby is mildly dehydrated. Thank you.
Mildly dehydrated, okay. Okay, I would like to do some more examination of the baby. I would like to start with the general examination. Can I know about the status of anemia, icterus, and also the if there's any peripheral cyanosis?
Those are negative.
All negative. I would like to know if the okay. I would like to go for the hydration status. You said is mild. Okay. Okay.
Clubbing, dehydration. Yeah.
Yeah, I said clubbing, dehydration, all this. If there is any edema or like in the legs, if there's any peripheral,
No, negative.
if there's any rash on the body.
Negative.
Okay, I would like to do focus examination of the respiratory system. Is there any deformity in the chest, any scars, any if there is any intercostal recession?
There is like mild intercostal recession is present, but there is no other deformity or any other those signs in the inspection. You can move to the next task.
Okay, I would like to do investigations in this child. I would like to start with the BBG, the venous blood gas analysis, arterial blood gas analysis.
ABG, okay.
ABG,
ABG is like with it in normal limit. You can proceed to the next one.
Then I would like to do the full blood count.
The office test and those findings are currently unavailable. You can move to the next task.
Okay, so probable. Okay, I would like to now talk to the mother of the Sarah examiner.
Yeah,
okay.
Sure.
Hello, Sarah.
Hi.
I have just done the examination and I've learned more about Sarah from my examiner. And I would like to say that I think Sarah is having a condition that we call is pneumonia. And then because based on the finding, because your baby is not feeding well and the baby has fever. And so I think it's more likely to be pneumonia. I don't think based on the history of the cough that there's not enough like sounds or any other added sounds present. I don't think we can exclude group. I don't think the baby is suffering from that. And I don't think your baby has any foreign body inside stuck in her respiratory system. So I can exclude foreign bodies as well. I can also think I can also exclude asthma because your baby does not have any wheezing or any other added sounds that I heard from the examination findings. And so
just to add, doctor, actually, one thing, maybe it was my mistake that in physical examination, moving to next task means when you are in the inspection part, actually, because you're going for the online exam, you don't have to go through that one. But normally in that exam, like when you are in the inspection side, and say go to next means you ask about the auscultatory finding, actually. So now
okay, I didn't understand. I thought next
yeah.
task means
Now let me clarify. Yeah, let me clarify that one. It's okay. I mean, in the added sound, actually, wheeze is present. Now you develop the case one time. I'm giving you scope to see that one. Yeah,
okay.
Maybe that.
And was there any effusion present? Just only wheeze?
There's only wheeze present.
Wheeze. Okay. So Margaret, I think your child is also having some wheeze in your in the examination. So it's more likely that your child might be having a condition called bronchiolitis. Because there are some wheeze present, or it could be asthma, so we cannot really rule it out. My current advice to you would be that we have to make sure
what I can
that
do, doctor, at this point, actually, what I can do with Sarah at this point. Can you give me some quick treatment here, actually?
Yeah, treatment would be. I think your baby needs to feed well because the baby is a bit dehydrated. So we have to make sure that the breastfeeding, you continue the breastfeeding. For fever, we'll give you some paracetamol, the baby paracetamol, which the baby can take. That will relieve some of the fever and the other symptoms. And the baby's oxygen saturation all good, so we don't need to worry about this. And I don't think your baby requires any antibiotic at the moment because based on this, it's more likely to be viral. And then I would
Doctor,
say
I have a concern here because you see, Sarah is having some runny nose, and I feel like because of this runny nose, she cannot sometimes breathe well. So, any suggestions for that one, just the drug would be fine? Are you giving any antibiotic here?
No. Antibiotic is not. I don't think your child requires any antibiotic here. because it's more likely to be a viral cause, because at her age, it's more likely to be due to virus. And then you said that the brother also had the same symptoms. So I will give some bronchodilators for to ease the wheeze as well. So I will give some beta agonist. I'll prescribe some beta agonist for that. And then I would give you a normal saline drop for the noses, so that if the baby's nose is blocked, you can just use some drops to clear away the airway. And if the baby does not improve more, then we can give some antihistamines, but that's in the late case. But I think for now, this will do the management.
One of my neighbor was telling that, her child was having similar kind of issue. The term you said, what bronchiolitis, and in her kid, it was some steroid was given. So for Sarah, would you recommend something like that?
For SARS symptoms at the moment, it is not, we don't give steroid to all patients. It depends on the types of severity of the symptoms. I think her case is very mild at this stage. I don't think we require any steroids, but of course, if your child develops more rapid breathing, if your child develops, if turns blue, and then if the child cannot feed anymore, please bring the baby back to the hospital. And at that time, we will have to give the baby steroid.
All right. So at this point, what do you recommend? Should I keep treating Sarah at home, or would you recommending advising to the hospital?
At her condition, you can take her home, but as I've said with the red flags, that if the baby has if the fever gets worse, and if the baby develops other symptoms like diarrhea or vomiting, as well as if the baby turns blue and the
so
breathing gets
you will
worse,
basically monitor her for a while, and then you'll discharge
yes,
accordingly, right?
I would monitor her for 4 hours at least, and then I'll discharge. Yeah.
All right. Great. Actually, or would you just be checking on Sarah, or would you be also calling anyone specialist for this situation?
At present, I don't think we need any specialist referral, but if the baby gets worse, I would like to refer to a respiratory physician, but I don't think we need it at the moment.
And what investigation you were giving Sarah at this point was a prescription?
Investigations at her condition, we do not actually do x-rays or any swabs, because it might be worse for the baby. But if we do think that the child is not managed, so we need to consult the respiratory physician or a senior consultant who can advise us that if we can do a nasopharyngeal swab on the baby for PCR-based test. But we would like to not expose the baby to radiation, so we try to avoid x-rays at her age.
All right. Okay. And because my financial status is not so good, in future, if this type of situation can happen, and if we cannot manage to admit her to the hospital and those things, is there any way you can help?
So are you an Australian resident, Margaret?
No.
You're not. Okay. So there are some social workers I can refer you to, and then they will probably help you out with the financial state. I will keep that in my mind, and I will talk to them so that they can help you out with these financial problems. And do you have any health insurance, which might help us out as well?
Health insurance, I do have.
Yeah. So we will, that's just social worker will then sort it out for you. No worries.
Okay. All right. Okay, great. So thank you so much. Yes. This helps. Yeah.
You're welcome, Margaret. And if you have any other issues, please do call me back, and I will try to help you again.
All right. Great. So thank you, doctor, for finishing that one, actually. So what do you think? How did it went?
I didn't understand.
That's okay.
That,
you know the things actually, yeah. But this is the the part of the exam. Every single point has to be there. Whenever we start, every single point has to be there. Actually, okay, like this, all this thing has to cover. Now, one thing I'd like to highlight. This is one of the major in the treatment for bronchiolitis. In Australian doctor and compared to our doctors, actually there's a lot different in the treating. That's one of the good thing you started, that there's no need for antibiotic, which is important. In our country is very common giving this antibiotic. So this is one of the important thing. This question will definitely come up for all bronchiolitis cases, that whether you're giving antibiotic or not, whether you're giving a steroid or not. You can tell rather in that way about that steroid, that Sarah is too early age group to give steroid. Also, there's another point. One thing that should have been mentioned for everyone who ever watching, for bronchiolitis cases, the nasal wash is like very important every like 2 hourly, like very commonly whenever it comes. This is one of the only mainstay of the treatment if it is the early stages of bronchiolitis. You tell the mother, like even if it's like a home treatment and thing, most cases, what they do is just like, just the nasal wash. That's the only treatment here actually. All right. And what they do additionally is to take a swab. All right. Very recently, my that sister's kid is also developed. It's because respiratory syncytial virus is so common in Australia. So it's so that's the only two thing. It's very
So,
similar. I've also seen with.
you
Yes,
know, the
please.
Royal Children's Guideline, what is that called?
Mhm.
One second. I think there they try to avoid the swab in bronchiolitis. You know that app, the
That's okay, but
Royals
Royal Children's Hospital guideline.
Hospital Guideline.
Mhm.
Yeah. So what to do about that?
Uh,
That's why, and they said
it,
you have to
this,
refer to a specialist.
yeah. Yeah. Now this part, we can take help from mostly from the John Murtak, because in John Murtak they have recommended going for the swab. So whenever like this is a if you or anyone has a dilemma that which one to choose in that case, because we always take the more evidence in that textbook first actually, because a lot of things that contradict, even RSCGP and textbook contradict. So in those particular cases we better go with the John Murtagh actually, John Murtagh reference, because there's an eighth edition now also. So it's because it's very new actually. So you can follow that one as a reference book actually. Of course, like the guidelines are also given there, but we have seen that, sometimes even our SAGE guideline, RSCGP, even rank hose, they also vary sometimes a little bit in certain some cases actually. So in that case, because books are made with so many references, so it's a little bit more reliable. So answer for that one, it's better to take the swab for they are not intended to give any antibiotic. That is almost common in every guideline and every book. But the nasal swab thing is quite common actually in Australia. Actually, this is one of the main part. Okay, so coming back to this one, this is where some of the highlighting points actually. So whenever anyone who enters into the room, check the question and see that what are the key points are given actually. Like Sarah, who is like 8 months, so which is like a below 1 year, right? So if we count that one in that way, that this is like a below 1 year, right? So below 1 year, very quickly, even if you forget, oh my god, what's the diagnosis, if you remember that's why sometimes MC1 knowledges are also below 1 year. How many diseases are there? So very few. I mean, in terms of the respiratory, this type of involvement with cough is bronchiolitis, one of the very predominant one is here. All right. So fever and the runny nose, which is like indicating viral. And then if it is indicating viral, pneumonia is mostly like, will go in a different way and may look like in that way, but, uh, pneumonia probably has more other features, so which may not fitting into this one, but some initial idea here is this below 1 year is given, it's most likely the bronchiolitis has been given. Is woken up with the cough and rapid breathing, noisy breathing. So noisy breathing is another part, and refuse to eat, so a lot of till things till that, I mean till then, looks like this can be pneumonia, can be bronchiolitis, and all of this thing. And that one of the part in the physical examination was important. It was accidentally Dr. Tasnova jumped into that one. I mean, probably I couldn't instruct properly that move to next task means your inspection things are finished, maybe we could just go to the next one actually. All right, sometimes this kind of instruction that come up. Sarah's brother is 3 years of age, had cold for last week and asthma, played up needing these things regularly. So anyways, like when few things are not clear from the history, definitely asking more about tell more of the investigation and probable diagnosis and differentials. All right, so you ask some of the physical finding would tell more about that one in that way, right? So coming back to this one, like this is taken from the RCH guideline. Okay, this is some of this part I've mentioned here. I just brought it from the RCH guideline. John Murtagh, you can also check. I'm sure all of you who just passed MC1 in John Murtag, it was very clearly mentioned about the swab test is the mainstay. You can see the swab test, which is one of the mainstay in here actually. Okay, and blood testing, this is like rarely has anything to do with the management. Chest X-ray not routinely done. So if you feel so that you need the chest X-ray and things, you can also ask the examiner. Dear examiner, I want to know about the X-ray finding actually. Something you can ask. So like he will say it's not available yet. Okay, so this is another way it can be to ask the examiner. All right. So this is mild, moderate, severe. So you can just differentiate, uh, particular things like that actually. So some mild, moderate, severe. So in our case, it was kind of like in between, like mild to moderate. So you can see like this case is a bronchiolitis, viral chest infection, often self-limiting. So about the reassuring, this line also needed to be added. That I assure you that this condition is very much under control and it is often self-limiting. So this line here is very, very important. Medication has like an antibiotic has no role, very clearly mentioned by the doctor, and clarify the treatment like maybe fluid and oxygen will be enough, and just monitoring, she will be fine actually. Rest and small feeding will be advised, and baby are sick up to this particular date and they become fine actually. So it's also important that this will continue for 3-4 days more actually. All right. So but cough may continue a bit more time actually. So these are some added information. They will also check your total knowledge sometimes. So you need to keep that one in mind. And this is also some of the things you can check in from the RSAGE guidelines, and you can also use them. If you're not adding the person to the hospital, if you can tell that you can monitor for few time, this is our case, this was actually kind of mild, so it is nice way that you'll monitor few time, but when you'll go back, check this particular things. Okay, if symptom not improving, high fever, lethargy, any rash, then quickly bring us here actually. Few of the additional point, this is text took from I think John Murtagh, patient education. So administer oxygen to maintain saturation over 90, respiratory support like by nasal prong if required, or if any severe cases. You can also add that one to improve mark, like some cases respiratory support may required. That's why initially we that's why you have to be careful after taking home. Consider escalation if severity does not improve actually in some cases. These things you can tell passively, like there's options of respiratory support and escalation is applicable if it gets severe. Actually, at this point, it is not required. This is a smart way to add few things. Actually, if you are sure about the management, actually, so this is kind of like if you remember long back, in our lot of papers, we used to write essay and the things, and we smart way try to add more point and just try to make them colorful so that the examiner they find out that, because examiner don't read so many things inside, right? So examiners see the points, and so if you just keep highlighting some of the points like that, that strike the examiner's mind. So immediately they give more points. Hydration, isotonic fluid, glucose. This is another thing, like if so you say fluid will carry mark, but if you say isotonic with added glucose support will carry more marks actually. Antibiotic not required. No education actually. Do not administer like these drugs. Okay, very clearly states from the book. Last but not the least, refer like 4R, refer, red flag, review reading materials, right? So it's just like additional thing. You can check MAR1 candidates taken from John Murtagh. You can see so respiratory syncytial virus, these are hypoxemia and all these things. And of course, in John Murtagh also, they mention more about that that nasal swab. So here, if you find the nasal swab, yes, here it is. So first line is a nasopharyngeal swab, as you can see. X-ray it is doubtful. So this PCR by nasopharyngeal mentioned in John Murtagh actually, and also they mentioned about the oxygen and few other things. Please check it accordingly. Yes. Respiratory observation user, especially with increasing respiratory distress. Okay, that is one of the things. So you have to clearly give some sort of clear view to the examiner to understand the severity. Understanding the severity will be very, very important to know in these cases. Right. So differences between croup bronchiolitis. I'm sure all of you must be knowing. Um, this is like major chart we used to use in part one, that croup, epiglottitis, and the bronchiolitis. A lot of things, mostly croup and bronchiolitis, you will get to see in the main exam. And epiglottitis is a more severe case with a more high fever and stridor, which is like, expiratory red cherry epiglottis. Most cases does not come in exam, but group mild, moderate, severe bronchiolitis, learn mild, moderate, severe. Previously, you may not learn mild, moderate, severe. Now you need to learn mild, moderate, severe for group and bronchiolitis. What is causing it? You see, virus is causing it here, and here parainfluenza viruses. So this is important. This is important in this case. So you see bronchiolitis, again, mild, moderate, severe. To understand the severity, how would you understand the severity? All right. So this is few of the things given: mild, moderate, severity. Nil to mild chest restriction. I said like mild in, things are present. So it was still the mild one actually. So it can be initially you can monitor, and especially treating at home, it's fine actually. But if I say marked respiratory distress or marked intercostal indrawing, then it's more going towards the moderate actually. So management will be also different in mild, moderate, and the severe. So you please tell everyone accordingly. Like if it's a mild case, you tell accordingly, like nothing to worry, just keep going with normal feeding, blah blah, this thing. Remember one thing, mothers are always concerned about the eating thing, feeding thing. So please ensure them that you just go with the normal breastfeeding, the baby will be fine in that case. And then if the fluid is required, you mentioned about a little fluid is required here in this case, so this is also important in that case. Okay, so everyone, I hope you understood about the small role play of this particular case. It was understandable. Thank you so much, Dr. Tasnuba. Do you want me to mark this one, or just okay, like exam is coming up,
No,
I
no,
can.
not now, not
Okay.
now.
Not now,
From
not
next
now,
month.
not
From
before
next
exam.
month.
Okay,
Yeah,
next one. Okay, no
yeah.
problem. All right, guys. So after 1-2 class, we'll start marking. So don't worry. So this is a similar, another type of case is present. Um, if you see this one can be a little different than the previous one. Um, the cough course at night, and cough which is followed by vomiting. If this is a case like that, in that case, this will be a case related to pertussis. You see this one. So uh, case is more long. It means, do you need history taking? So no. So there is no history taking. Okay, so no history in this case. So this is how always remember in the exam. Longer information means no history taking actually. Keep that in mind, otherwise people confuses these things so often. All right. So there'll be a whooping cough case. Now how we understand a whooping cough case? Okay, 5 year, that's not the main thing. Cough and runny nose for a week. All right. Cough was dry in nature and but followed by vomiting. So this was one of the main, like either they will tell you persistent cough, or either tell you cough is followed by vomiting. So probably the early stages of whooping cough actually. And inspiratory grasp is another finding. And the cough become worse at night, but many cough can be worse at night. Example, ZRT. So ZRT can be also a differential in this case. All right. Now, if we are trying to deal with a whooping cough case, in that case, you see pertussis and a whooping cough followed by vomiting. So when you explain, say, okay, Melissa, like in your case, this is a case of pertussis, because your cough is followed by vomiting, which is a first sign that this can be a case of pertussis. You see, I was trying to prove and establish the case actually. Just don't tell that okay, this is pertussis. Why it's pertussis? You tell at least something for that one, or if there is a supportive X-ray and have a X-ray and this that. So as like a generally, how it is done in Australia. So this is how we can do that. Emission caused by a bug or telepertussis is important. More serious babies less than 6 months age. Many babies can have whooping cough from older children. So it might came up from somewhere. All right, this is another thing. Cough may persist for a few more weeks. This is also to mention, like when it is happening, do mention it. How long it will persist, do mention it. Are you admitting for this condition? Mention it. In this case, is even more important thing is included. You need to isolate the patient, right? This is a case where you need to isolate the patient and notify the DHS. Now, DHS is nothing but Department of Health Service in Australia. There are some diseases are communicable disease or notifiable disease. This is one of them. It's a very dangerous one. Okay, so but all you can do later is also take nasophrenolone. If you remember from part one, in pediatrics, two of the cases, this swab is very important. One was that bronchiolitis and one is that pertussis. This swab is very important. Or you can also do blood tests to take to confirm the cough within last 3 weeks actually. So this is for more important. I have highlighted few key points here. You can see key point. Now, this is how you try to make sticky notes. Now, if you see in my wall, there's few things are written as a sticky note. Actually, I mean, many of you used to do sticky notes in your wall. Now what's your job? Now, whenever you are studying um, this pediatric with us, we'll try to mention for different cases. It will look like this, but I want you to also mention things like that. That these key points you definitely want to mention in your case actually. So these are the things. If you want, you can make it, and it takes much less time, and you can post them in your wall. Now, if you have passed the exam and your wall is already full with MC1 things, you might feel sad to remove them, but you can remove them. But the new thing are coming up, which is a good thing. So you can start in that way. So previously we just saw with the case of bronchiolitis, you can highlight few points. With the case of this one, you can also highlight, already points are highlighted. So cough followed by vomiting key, then there's a part that is poditella, and there'll be persistent cough diagnosed by, yeah. So by doing a nasal swab, notify DHS, um, school, and is there any antibiotic required, and 4 hour. So these are few points. So notify the DHS. This is very, very important. Now, about the antibiotic, I put a point with a question mark. What does it mean? Antibiotic should be given to anyone who is at high risk actually. I mean, those are with the pertussis case living in a close proximity. So for them, this prophylactic antibiotic is required. So isolation important, notify important. This prophylactic antibiotic is also important. You have to mention that one to someone. So among the treatment of pertussis, you can see is antibiotic is required or not? Yes, it is. So quite important. So azithromycin, as you can see, and this macrolides if issues with the other drugs. And you can see prophylactic regimen, same as the treatment, this regimen actually. Prophylactic should be given to whom? The family members who are living in the same house, or someone in recent time was in the close proximity with the patient. Maybe the patient go to the care center, the teacher is carrying the baby, or a person is carrying the baby all the time. So that is a high risk cases actually. How to prevent? This is how there's like vaccination and all these things are there, but you can just have a look how the vaccination program and how we can prevent now actually. So this is the thing. More details, you can see the RCH guideline very nicely given that from the in that RCH guideline. So I try to make a combination with a John Murtagh and at the same time RCH guideline here actually, and of course some important point highlighted. All right. So critical error for a pertussis. This one I took from the handbook actually, and that's why sometimes handbook is important. I told some nice critical things that even fail to make a proper diagnosis. If you fail to make a diagnosis, you don't realize by seeing this thing, cough followed by vomiting, you're failed probably. And you may to make a proper diagnosis. Not notifying the DHS, you might fail. It's very important. You need to notify the notifiable disease. Fail to give the proper treatment, like you fail to give antibiotic and all this thing in a pertussis case, you can again fail it actually. Is it clear, everyone? Understandable so far, guys? Please let me know in the comment section. Is it clear, the pertussis cases, guys? All good? Doable, guys? It is doable. I believe it is still very doable exam actually. Strong belief is very important. Believe me, those are with a strong believer I'll pass, they eventually clear the exam even with quick time. I have seen. And some some people say MC clinical, it will take so much time to pass. One time passing it is impossible. Now if you tell these particular words, you are one step towards the failing actually. Okay, you take a decent amount of time, you just keep yourself making sharp, 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 better than others. When you do a role play, if you feel okay, I have to be better than this person. This is a technique I'm telling any role player, throughout your practicing session, you'll find a lot of role players actually, right? Like while you go to do, like, try to do role play with a lot of people. So if you see that okay, someone is better than you, you have to be better than that person actually. So if you have that kind of aim, definitely you will overcome that one, right? Yes. Yeah, a lot of MC1 knowledges actually, those came from MC1. Now I think correlate a lot of things. Okay, and I also give you the page numbers that will save your time to go to, like, Karen. But I would also say enter into Marwan will be. So Marwan, maybe at the end of the class, someone please remind me how to utilize that Marwan. I mean, utilize the technique of Marwan, like quick searching technique. I will show you guys actually today by the end. Okay, so that will be an additional set. Like, so if you keep all this thing, nothing will be left over, and you try introduce your own technique by this time. That will be more than enough. Now, this is another case, So today I'm just trying to show one of them, and because not many people are coming to role play so fast, so maybe we can do the same things role play, because you guys can read a little bit and come to class, and the same thing I can do a role play with you guys, so that at least I want the very first one. Okay, the known case, you do the already known case, no problem, but you just start the first one. Actually, that's the only thing I want. Okay, you see a case, I mean, at least try to make the diagnosis. Okay, like, this is open class, guys. Everyone, if you want, you can just come and just make open diagnosis. You're a GP in the clinic. Next patient is a 10-month-old John with brought by father. Senders, he's having noisy breathing. Okay, so history is like some history part is giving. Started night, this harsh and orso and crying, runny nose, zappated. On examination, these are the strider and it's muscle and all this thing. This is how in the um, online exam, physical examination finding will popped up in your screen. Okay, so intercostal retraction is present and some sound and a strider. Now, can you make a diagnosis? I believe enough information. There is enough information to make a diagnosis. Some guys, please quickly mention in the comment section what do you think. So this is nothing but the inspiratory stridor and all these things. It's a classic one. What do you think? This is a case. These are the key points. These are the key points, like inspiratory stridor, vital use of accessory muscle. Now, I'll give you another chance. How you can get the full mark? You say group, you get half. But how you get the full mark then? That means you have to mention it. Either it is a mild, moderate, or severe group. Now, few things you learned in MC in different way. You learn in MC2 a little different way. Nowadays, don't tell anything directly. So is it a grade 1, 2, 3? Is it a mild, moderate, severe? Remember in that way. So what do you think? Is it a group? Is it epiglottitis? Is it a bronchiolitis? So in that case, okay, this can be all our differentials. These all are differential. You need to keep them, all of them in mind. So it is said inspiratory stridor. This is out already. This is out. Foreign body, there'll be a choking feature, and X-ray can only confirm. So it's not the answer. Bronchiolitis under, you'll find someone under 1 year kid, and more other, not like a stridor but a wheeze feature, so that's also probably out from here. Anaphylactic, there will be reaction, rashes, respiratory, wheezing, and all these things, which is also not present here. So in that case, with all that note, like history might tell you barking cough and this, that. So this is a case of, what do you think? This is a case of group. This is a case of group. Actually, it's mentioned strider, it's mentioned inspiratory strider, right? Inspiratory strider is more towards the group cases. Of course, you enter in the exam hall and you do ask a lot of things to the patient and examiner, but to be honest, you see this case, can you really make a diagnosis? This is a group. Are you that confident to make at least a diagnosis by seeing this question? This is a group. This is that MC1 knowledge we need from you. Okay, if you can use that knowledge, that making a diagnosis, okay, this is a group, the rest thing is just like the MC2. You make the right diagnosis, you are one step towards passing whenever you see that question. Now here is the technique. When you see this question, actually in 15 seconds you can make a diagnosis. Then the remaining thing we start processing. Okay, history, this, that, then we can remember that is sticky note or our note, whatever that reflects, are useful. Okay, these are the point. Definitely I will tell about these things. In this way, if you go, you will not miss any major point. That 2 minute is very, very important outside the door. You actually can process in your brain. Okay, this 6 points. Okay, I know it. Okay, you are ready for the exam actually. Right. So what to do in this 2 minutes? Actually, see each other faces like that. There'll be other people, you know here and there, so not that's the point actually. You probably see the question, close eyes, try think, okay, what are the 6 point. You try to guess in the beginning that, okay, is history is required or not. Try to talk to you sometimes, so like, is history is required? Okay, history not needed. Okay, what are the 5 or 6 key points? Okay, it's a group case. Okay, so it's a group case, it's tried or this that. Okay, physical examination, I'll ask about respiratory, this that. Okay, in the treatment. All right, done. Okay, so is that's how the confidence should be, that this case, you are entering like a champ. This is the thing. So this is the thing. It's a mild, because sometimes a few things you get to know by entering exam hall. By talking to the patient, we get to know few things. But many time, if questions are long, you can make the diagnosis. But mild, moderate, severe, after entering, you get to know sometimes. Okay, so mild, moderate, severe, these things are given. Severe adrenaline, moderate prednisolone, mild cases, and no such treatment except for small feed and oxygen. These are the particular things are good. I hope you all remember, right? Group treatment case, mild, moderate, severe. So depends, whatever is the case, you mention accordingly. That's the only thing. Now, one more thing, let me tell you. One time in an exam hall, they brought some sound. This is because there is no kid is sitting near to mother. They brought a sound and playing that. Doctor, I record the sound of my kids. Yeah, so they can show you the sound. So this kind of thing can happen. This kind of thing can happen. Also be considered, any cases can be make a telephone case. You understand this thing, guys? Those are new. You heard about telephone cases here? Please mention in the comment section. Have you heard about this, telephone cases? I mean, in the main exam. So will be a lot of cases would be telephone cases in the main exam. There will be no one. You enter, you see there's no one there in the hall. You after entering. So there's only a telephone is sitting, you go and pick up that one. That's how the things are. And you keep talking, keep advising. That is the thing. Because in these countries, so many patients you have to deal by phone. Is that correct? I mean, those of you are living, right? So many things are done. Even the GP, they don't want to see you. Oh, okay, what is your problem? Okay, okay, take paracetamol. Bye, bye, bye. So that's how it is so common in Australia. So that means those telephone cases are so common in the exam too. All right. So please be careful that every cases can be converted into telephone cases. Actually, the mother is anxious. Doctor, my kid is having Paul, already this Paul is having this, that now. So you need to calm her down. Don't worry, I think he will be fine. Plus tell me what happened actually. All right. And please tell me where you are now and how Paul is doing now actually. Okay, it's very important to know why this question, why you are, or someone who is calling, doctor, I'm not feeling well. Is it important to ask you where are you now? Okay, it's actually very important. Any stroke cases, anything like that, please ask, where are you now? All right. Okay, is there anyone at your home as well? Is there anyone at your home? Please make sure, because if it's a serious case, the patient might lose consciousness, and phone will be cut off. You don't know, and you can't really recognize always. The patient might not be at his own home, right? So it can be in different home. So where are you now? So this is important. Is there anyone at home? So if there is anyone at home, at least they can contact or communicate or take that person. So this is an important tip for the telephone. Telephone, I think in this current batch, I'll give you some more tips like that. That in telephone, please ask starting, how you are doing, and are you okay? Like it's a very common thing we ask, are you okay? Where are you now? This is the thing. Yeah, no one at home that at least they where are you, can you tell the exact address actually, in case the phone is cut, so that we can communicate with you. That's how the things are actually. Okay, so this is important actually, so, or you can ask one thing, are you at your home which is registered? Are you at your home which is registered? Because in those countries, with the phone number and the registered guideline, can you tell me your ID number? If you're the GP, your patient would have been in some ID or things like that actually. So, at least get something from the patient. Okay. So we were discussing this thing, group epiloid bronchiolitis. Again, it came up, and this is about the group actually. So try to make some lines. You see, this line has been taken from the John Murtak patient education. I suggest you guys to improvise these lines in your own words, because everyone will be telling the same line, and their MC examiner, they know that you just did rote learning. Did you remember anything about the rote learning? I'm not sure if anyone found that phase of doctor, that suddenly some of the results were withheld and mentioned your study process was rote learning actually. So there was like, I think 2000, I think 20 or 19, some candidates, suddenly texted after exam, doctor, my result didn't come. It said rote learning. I was thinking, okay, is it because of recall or something happened? We don't know. Actually, sometimes previously so many recall used to come. So the response time for one particular question was too fast. Oh, this is that question, A. Okay, this is C. The response time, this is automated. So, this is they try to figure out that some candidates are answering too fast in the exam for some question, and then they detect them that okay, this is probably rote learning actually. So result will withheld. So later I told them that email them that I was so confident with my exam, and my preparation is good. So that's why I answered very fast actually. They answered that one back, and the result came very quickly after. But it's still, it was 1 month it was withheld, because their system, it is very slow. So that's the thing. Now this rote learning thing, I talked to some of my other tutors. One of the tutor is also a bit linked to MC Clinical. So few updates we get from that tutor as well. That so this thing has been introduced also to MC2, that this rote learning thing. If you are sounding too much like you just memorized the handbook, and kind of like that, your everything is perfect in the exam, but you are failed. Understand the point? Everyone clear? If you sound too much like you know like a pattern, you might fail the exam again. Okay, so a bit innovative, few approaches. In the initial approach, you should find your own word for the cases. You should not just what I just told, you need to follow that one, because my one might be followed by many, but you should have your own approach of telling. Okay, you should have for all these things, like this is croup, a viral infection, swelling of the voice box and windpipe. You can come up with something different, right? Like there's a website like WebMD. You can search there. Actually, it's mostly for the patient, because you have to tell things in layman's term. You can't use the word larynx. You can't use the word trachea. This is swelling between your voice and the windpipe, and that's how this harsh sound is coming up actually. Okay, this makes the airway narrower and harder to see. How nice lines are that actually. Normally we don't use this kind of lines, but you are using it to a patient. So often like normal, followed by harsh barking cough. And children at this age groups are more common. I mean to say 6 months to 6 years actually. And don't worry, it does not require any treatment, because it's mild and it will get better in a week. You don't need to always tell like 3 4 days. It will get better in a week. These are like so things. um, Airway swelling and these things will reduce, and things will be better. I'd like to assure you, these situations does not require any antibiotic, but I'll definitely give you some Panadol or paracetamol for the fever, and then use the review red flag and the blah blah these things. Actually, please don't bring the baby back if there is any blah blah blah, rash, fever, all these things. All right, so this is few of the things. So cough, breathlessness, stridor, not feeling. These are some of the keywords, right? Always we need to find out the keywords. So cough, breathlessness, stridor. Stridor is a familiar word in group, and not feeding well. These are some of the keywords. All right. Please keep it in mind. Some cases you can also Google it. I mean, go to YouTube and search group sound. Actually, you'll find it actually. Group sound actually. So they might ask you, doctor, I've recorded the sound. Not recently, but previously I've seen. So be familiar with that one. All right. Epiglottitis. I mean, if you remember for MC one slide, this was there. Yes. Tripod position, right? And some extra thing. Some rare cases, you might get X-ray directly on the room. That if you ask for, is there any X-ray? Yes, X-ray is present. So red cherry epiglottis for epiglottitis, and this is stipple sign is for group actually. Get familiar. Radiology can be given inside the room actually, or radiology can be given in some of the uh, online cases too actually. Some cases it's already might be given along with the question. All right, so that's one of the things. So this is another case. You can see any cases. What is this cases about, guys? Let's try to detect this one. Let's see, who comes out with a faster answer. But this one will be difficult because 2 year, but complaining of recurrent cough for 4 months. So history is involved. It's difficult to make a diagnosis from the beginning, but at least you can try. Okay. Keyword recurrent cough for one. Now I'm trying to show you, how different it is from MC1. So the recurrent cough for last 4 months. Now you should start thinking recurrent cough for last 4 months, what it could be. Is there any failure to thrive? Quick question. Some of you are going to um, towards, yeah, some of you are going towards cystic fibrosis. Is there any failure to thrive? So far not. Maybe in the main exam they might tell you. All right. So recurrent cough at least for 4 months. So most common cough is a post-viral cough actually. So differential diagnosis for recurrent cough, a lot of thing it can be the recurrent cough, like asthma, GERD, post-nasal drip. Then you can see something can be dry post-viral cough and pertussis. So a lot of things can be of recurrent cough. Now, this is initial. This is initial to keep it in mind because they said that you have to take a proper history. So when you start asking the mother the proper history and all these things, then more information will come up. Yes, from the very beginning of her life, she's having this breathlessness problem. Now you get more clue. Okay, this is going towards asthma. If they said has bloating, get up at the night time because of cough, it is going towards GERD, correct? Then, if they said no, there was a respiratory infection, often sometime it happened and this thing happened, then you think post-viral cough. Now you need to go more underneath why repeated infection is happening. Maybe you can get a clue for cystic fibrosis. So you guys are not incorrect, earlier if you say, all right. And sinusitis, is there any pain in this particular areas or any redness and these things? And after respiratory tract infection, this thing has happening all the time. So you can also think in that way because it is said a longer history of cough. You can also consider TB and a travel history will become also important in this case. So this is how we need to approach with some of the cases is very important actually. All right. Let's come to solve in another case. Don't worry, we'll do more role play next day. And today we're just showing, but next day definitely I will ask and I might mark as well actually. But first 1 2 class, I try not to mark candidates actually, but otherwise your every statement will be marked actually. Now, here is a case. Let's try to find out. Let's see who is faster is answering. A 10 weeks pregnant lady, and this G2P1, she um, her first, the first one is actually, sorry, her first one is given in that way. Her first child, Mary, aged 2 years, was born prior to arrival in Australia, is having recurrent UTI and recent diagnosed with cystic fibrosis. She came to discuss cystic fibrosis and chances of having another baby with this condition. All right. Any cases? Now, this is, I think, already been mentioned that cystic fibrosis and explain the nature of cystic fibrosis. This was a case actually. So cystic fibrosis can be also, you can put under the cough thing actually, like recurrent respiratory tract infection, recurrent cough. This is how it might look like. This recurrent respiratory tract infection is the main key here. Okay, then you can find towards this one as a cystic fibrosis. ABCFP, there's a mnemonic you can remember. All right. You might also find a differential related to chronic cough actually. Okay, so some can be acute cough, some will be chronic. So habit cough or psychogenic cough, please remember we saw a question also I think recent time with a psychogenic cough, so you also need to be careful with that one. Like psychogenic cough might also come in the exam actually, they might fake it. So you see this one, like let me assure the child is physically healthy. I mean, examination finding, when the role player will keep asking every system, the examiner will still normal, normal, normal. You will be surprised, nothing. Then what it is? Then you'll think, okay, probably it can be psychogenic cough. A condition about psychogenic cough, have you heard about it? This is repetitive cough usually occurs in absence of underlying cause. It is common at this age group, but not serious. All right, related to stress or anxiety. It's a keyword. All right, can be related to stress or anxiety. So sometimes have you noticed, when people around him, it worsen more. This particular thing you will ask in the history. Have you noticed, like, whenever you were there, then the cough is more? Yeah, I think so. Yeah. So in case of parents divorce, it seems that the history of the child, it can be also. So because he's in anxiety, he's not feeling well, his parents are not around, or parents are fighting. It's also very important that, it is told that if parents are, like, fighting or shouting, uh, the kid should not be present in the room. All right, so for all of you, this is a suggestion that it happens with everyone. If shouting things are happening, please make sure, you keep the kids out of the room actually, so they grow up seeing that one. It affects psychologically too much actually. Let me assure this will go away by itself actually, and we will work on his stress and anxiety as well, what is causing it actually. Right, so maybe more family meeting and this thing might help. So this might be related to more towards the psychogenic law. In the management, isolate the stress is more important, and so you have to limit the stressor factor, and certain point referral to psychologist may required actually. If doesn't work, then I can arrange to psychologist. Like if she asks you, you say no, no doctor, it must be a mistake. No, so I'm sure. And is it necessary to refer to psychology? At this point, it is not, because it goes away. Like, just work on him, be with him, be nice to him, make something nice for him. So you just use some nice words actually. And, as I mentioned, arrange family meeting. And lastly, the 4R red flag. If you see any child is not doing well or not growing well, feeding difficulty, wheeze, and all this thing, and hemoptysis, then quickly bring him back. Then we'll think, okay, this is actually organic cause actually, and we are not going to admit her, the kid now. Kid seems quite fine. I can assure you that one. All right, so this is how it can be. The things are all right. So these are like the some similar additional condition. And this is the last slide actually. As I mentioned, next day, we will be also uh, doing role play on that one, probably this coming Saturday. Hopefully, I will be doing the role play. I want all of you to do role play. It's okay, we can practice, we can just keep practicing. The first one, just we might be a little nervous. Once you start with me, definitely then you'll just get going. Actually, confidence will just get higher and higher. All right, so this is like child with the cough cases. You see, it's not too difficult. So this like a 3 or 4 cases, right? 3 or 4 different cases for the child with cough thing. Is it manageable, guys? What do you think? Is this particular thing is manageable? What do you think? I think it's a doable. And you can see one thing, a lot of your MCQ knowledges are also reflecting here. So if you passed recently, it's a very good thing to start. One more thing, there's a two type of doctor message me. Doctor, I'm thinking to start after 4 months. What is your suggestion? I can't really, join now. Now, your MC1, those knowledges will fade away in 4 months. Correct. So now what to do? Now I tell them, like, we have a option that you can take away the course. Maybe this batch, if you can't join, you can join after 3 or 4 months. There will be another one. You can join it for free in that case by taking the content from this batch. But what you have to do every day, 1 or 2 cases, not the full slide, but every day 1 or 2 cases. You play the video a little bit, see the case actually. Study like a 2.5 hour, that's fine. So please make sure your this knowledge things are reflecting. But if you give a 4 or 5 months of gap, it might be little difficult actually. Some of you are charged up now. I can see that just you just finished that MC1 and you are ready to give everything. So that one, you can utilize. But if you have some binding, some people has some family issues, personal issues, because for MC1 you are stuck for 8-9 months. So a lot of people want to take a break. So in during that break, this is the suggestion. Every day, at least a case, at least 1 or 2 cases, for God's sake. All right. So thank you so much, guys. If is there any other questions for